Hello, doctors. Good evening. Welcome to this experience sharing program on managing PPH case studies from labor room. This program is brought to you by Heathrow Healthcare Company. Heathrow Healthcare is a company since 1993. This has 25 years of excellence, 36 state-of-art manufacturing facilities, 300 plus products and portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV APIs and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing four biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Experience Sharing Program on Managing PPH, we have got Honorable Speaker Dr. Jaydip Basu with us. Welcome, Dr. Jaydip Basu.
Thank you, my pleasure.
Dr. Jaydip Basu is MBBS MD. Sir is a consultant gynecologist and obstetrics in Calcutta. With this brief introduction, I'll request Dr. Basu to start the session. I'll run the slides, sir.
Please. Good evening, everybody.
Good evening.
Today, there is going to be an interactive discussion regarding a slight overview of postpartum hemorrhage and what are the medicines which are present in our armamentarium to prevent postpartum hemorrhage. We can always treat postpartum hemorrhage after it has occurred, but we should try to prevent it, because as we know, prevention is better than cure. So today we'll be talking about molecule carbetocin, which is specifically meant for prevention of postpartum hemorrhage. Now, before we enter into the subject proper, a few lines which we are all aware regarding postpartum hemorrhage. We all know that pregnancy is a very pleasant journey, tiring perhaps, but whether it is normal delivery or cesarean section, at the end we have a crying baby and a very happy smiling face of the mother. But there are certain conditions in which after delivery, whether it is by cesarean section or after normal delivery, the bleeding is more than normal. Then that is known as postpartum hemorrhage. To give a textbook definition of postpartum hemorrhage, it is said that when there is bleeding more than 500 ml in a case of vaginal delivery, or more than 1000 ml, that is 1 liter, in a cesarean section, we also say it is around 800 ml in a C-section. We say it is a case of postpartum hemorrhage. Now, if it is within 24 hours of the birth of the baby, it is known as primary, and if it is after 24 hours after the birth of the baby, it is secondary. So, if it is within 24 hours of the birth of the baby, it is primary, and after 24 hours, it is secondary. Then I'll go to the classification, minor, moderate, and major as we go along with the slide. It is unfortunate yet common. It is one of the leading cause of maternal mortality, accounting for about 35% of all maternal deaths, especially in underdeveloped country. We are now not exactly an underdeveloped country. We are a middle-level country going to be a superpower very much in the future. But unfortunately, this maternal mortality is seen in much more in the rural areas. But fortunately, due to the improvement of the medical infrastructure and the hospitals, it is coming down. This data perhaps it slightly perhaps would have been true say 7 or 10 years ago, but at present it is not that high. Maternal mortality rate in developing countries was 240 per 1 lakh live births compared to 16 in developed countries. So it is higher in developing countries, and definitely it is much less in developed countries. The cause we shall discuss later. Global PPH index, 14 million women suffer from PPH. Incidence of PPH is reported as 2% to 4% after vaginal delivery and 6% after cesarean section. That is not a very much of a difference, but to be very frank, in our practical lives, we see the postpartum hemorrhage is slightly more in case of vaginal deliveries, because in case of cesarean section, we after delivery we take out the entire placenta, which may not be possible in or may be missed, or a placental lobe may remain after a normal vaginal delivery. So in case of normal delivery, where we cannot see whether we have emptied the uterus completely, the chance of PPH is high, and you should have be very more monitor the patient more in the case of vaginal delivery. Wherein in the case of C-section, we are opening the uterus. We after delivery of the baby, we completely empty the uterus and see though there are no placental tissues or bits left. Achha, next, etiology of postpartum hemorrhage. These are the famous T's which we have come across in our student life. Student life, one is the tone, uterine atony is the commonest. Inability of the uterus to contract, which may lead to continuous bleeding. Thrombin, which means another T. Coagulopathy is failure in clotting. It is seen mostly in case of preeclampsia or eclampsia or ITP patients. In these patients, this coagulation problem is there. And in case of tone, uterine atony, it is, we shall come to that later on, where the uterus is over distended in case of big babies, polyhydramnios, twin pregnancies, where when there is over distension of the uterus, immediately after delivery, the over distended uterus finds it difficult to contract, and that is that it becomes flabby. So the bleeding is much more. Third is trauma, injury to the birth canal, that is not in cesarean section, but definitely it can be seen in case of vaginal deliveries, in case of difficult vaginal deliveries where there is forceps application. Now forceps is nowadays going out of fashion, because we are now the dictum is safe motherhood and we practice safe obstetrics. Forceps is now not being used as much it was seen, say, at least 15 or 20 years ago. Third is the tissue, retention of placenta and clots and abnormal placenta. This is important, retention of placenta after normal delivery. If you think you have taken out the entire placenta, so you must not pull before the placenta is separated from the uterine bed. So we know gradually pull, we know true lengthening of the cord, so you must take out the placenta gradually. In case of twin pregnancy, you may have two placenta or you can have a very big placenta. You must never ever hurry. That is important. You can understand where there is a gush of blood, that is the time you know the placenta is separated from the uterine bed, and then you take it out. Third, another case, in case of retention of placenta or abnormal placentation, is seen in case of placenta previa. In today's we do sonography, we know placenta previa, we don't go for normal delivery, go for C-section. But in case of placenta previa, always please remember there is a possibility of placenta accreta, increta, prakreta. In case of abnormal placentation, that is placenta previa. So to diagnose in case of placenta previa, in what I practice and many of my colleagues also practice, we do a colored Doppler study of the placenta in the antenatal period at around 36-37 weeks to find out whether the placenta gives a placenta accreta, increta or prakreta, because during delivery, after the baby is out, if you have difficulty taking out the placenta from the placenta plate and it keeps on oozing, you take a consent for cesarean hysterectomy prior to the cesarean section. In this case, in this way, you can try to prevent postpartum hemorrhage and save the life of the patient. Next slide. Now, I'll quickly run through this clinical finding of postpartum hemorrhage. When you see a postpartum hemorrhage, the first thing you know during delivery, whether normal delivery, C-section, patient is on IV fluids. So already IV fluid is running. We also always give whatever carbetocin or oxytocin is already been given. So when in this, and we during C-section, the patient is already catheterized, the Foley's catheter. If in a case of normal delivery, the patient has not been under continuous catheterization, put in a Foley's catheter. So pulse, BP should be measured. Do always do a catheterization because empty bladder helps in contraction of the uterus. And also urine output measurement is very important. Increasing abdominal gut we don't do it these days. And in case of you must remember, supposing you are doing you are in a situation where you have to conduct a vaginal delivery in a case of post-stage pregnancy. So how you see the patient is bleeding. If the uterus is contracted and the patient is still bleeding, think of scar dehiscence or scar rupture. Okay, and you must keep this point in mind. So loss of uterine contraction means, or if there is, you see that after the baby is out, uterus has become flabby and patient is bleeding because the scar may have ruptured. So and that the patient is bleeding. And so pulse, blood pressure, vaginal bleeding, urine output is the basic initial things which you do clinical examination. Then you go for the investigation. Next slide, please. Poor uterine tone, abdominal plant, uterus will relax, boggy and soft, which we have, which is a feeling we most of us, many of us have felt in a case of atonic PPH. What we do, you see the full blood count, coagulation profile, your friend, you send for coagulation profile, urea electrolytes, then uterotonic agents we give, oxytocin, because oxytocin we give, not carbetocin. Carbetocin is for prevention of PPH. After PPH already started, we do not give carbetocin. So oxytocin means oxytocin. And we give prostaglandin PGF2 alpha or alkalized by methergine, which we are very much familiar for the last 30 years. Now, if the patient is not responsive, fluid management and ultrasound facility is there, shift the patient to the USG room or do a bedside USG if the facility is available to see if there is any intra-abdominal bleeding or collection. Next is, in case this is for normal delivery, this is applicable. In case of tears on trauma, it is in where it is in case of difficult cesarean section, second time, third time C-section, if there is extension of the incision scar, there will be bleeding in case of C-section. And in case of the next comes from uterine rupture. Uterine rupture in case of the two cases. One is supposing a patient has 1 or 2 C-section and she has come in a full dilated os condition where you don't have the time to do a C-section, so you go for a normal vaginal delivery and you end up with a scar rupture. Uterine rupture, supposing you are conducting a normal delivery, uterus is contracted, suddenly you see the uterine contraction is lost. Or immediately think of uterine rupture. It happens at the fundus, not in the scar, because even a primary patient, prolonged labor, and in case of malpresentation, there will be uterine rupture. Then supposing you have already delivered the baby and you see that there is cervical tear, that is cervical tear, vaginal tear or laceration can be there in the so that is also cause of postpartum hemorrhage. Investigation, as I said, inspection during C-section is by the extent of scar rupture, extension of the incisional scar. And management is most important is to identify the cause of the PPH. In the case of normal delivery of the C-section, whether it is due to atonic PPH or due to scar, tears or laceration, you identify. We can always identify that. We do it within a few seconds because we have been doing it from practicing for the last few decades. So we are aware of how to handle it. But having the supportive infrastructure is very important. You need a very supportive operative team, OT team, a labor room team, and a laboratory, sonography. Many places do not have any blood bank, so you have to arrange for the blood if necessary. Now, coming to the third side, retained tissue, placenta, membrane, investigation, sonography under anesthesia, you do a manual removal, etc., coagulopathy. Management is immediately medical with blood for blood, and plasma, etc. in case of extreme conditions. And surgical, if there is trauma atonic PPH, unresponsive maximum in case of atonic PPH, you may have to see supposing you may after cesarean section you can have atonic pH, after normal delivery you can have PPH. It is not responding to any type of oxytocin. If you do during the C-section, the abdomen is open, you do bilateral uterine artery ligation, or you have conducted normal delivery, medicines have not working. It happened to me recently in a case of twin delivery. Bleeding was so profuse, I have to, after normal delivery, I have to open up the patient and do a bilateral uterine ligation, and the patient is stable. So these are so most important is attempts should be made to identify the cause who are bleeding and in parallel with resuscitation. Next slide, please. So what is the rationale for the development of carbetocin in new heat stable formulation? Sir, will you now say something? Then I can always say. Dr. Prashant.
Sir, no, sir, you can say, sir.
I can call.
Yeah.
Okay. So so coming to the question of why did this carbetocin? We had it oxytocin for decades, and it's a very traditional medicine. It is still over there, but why the need for a carbetocin was felt? So what is this carbetocin? It is an oxytocin analog, synthetic oxytocin analog. It is a carba modification of the disulfide bridge, so it is known as carbetocin. It is also an oxytocin receptor agonist. It is stable at room temperature, which means it does not require any extra logistics for refrigeration, unlike oxytocin. It is long lasting, has a shelf life of 24 months at 30 degrees and 75% humidity. That is in a humid country like India and in the rural areas, which means it can be kept without any refrigerator facilities. It therefore avoids the need for cold chain storage and logistic, and is provided in a vial. So next slide, please. So when is that uterotonic agents are applied? Time of administration at the crowning of baby's head, at the delivery of anterior shoulder, at the end second stage of labor, following the delivery of placenta. In case this is possible in case of single pregnancy. In case of twin pregnancy, definitely after the second baby is out, we will give the uterotonic agent. Prophylactic use, prevention of PPH, and active management of third stage of labor, and therapeutic use, management of PPH. It is basically now this prophylactic use, prevention of PPH is related more to carbetocin. But in case of oxytocin, methogen, will come to that step by step. Next slide, please. So, what is carbetocin? It is a synthetic long-acting analog of oxytocin. Why it is long-acting? Because of the carba modification of the disulfide bridge. So carbetocin, it is this modification which has made it long-acting. And it is synthetic because it is synthetic, and it is an analog. Therefore, because it is a modification of oxytocin, and it is therefore it is analog of oxytocin. So and therefore it prolongs the half-life. The half-life is around 40 minutes, whereas in oxytocin it is 5 minutes. Therapeutic indication, it is solely to be used for the prevention, not for the treatment. Solely to be used for the prevention of postpartum hemorrhage due to uterine atony. Why we are focusing on uterine atony? Because that is the commonest cause of postpartum hemorrhage. So carbetocin, uterine atony, prevention of postpartum hemorrhage due to uterine atony. This is a very significant statement. Uterine atony is the commonest. We try to prevent the postpartum hemorrhage due to uterine atony. Give the carbetocin prior to the onset of postpartum hemorrhage. Now, one vial contains 100 microgram of carbetocin in 1 ml solution for injection. Now, we can give it by the intravenous route. If we give by intravenous route, it should be given slowly, preferably over 1 minute. It can be given by the IM route. So just we give a IM route, just push it. Nothing slow about it because it will go into the muscle and then get absorbed. Whereas it is given IV route, it is given directly into the blood vessel. So we have to give it very slowly. Next slide, please. Okay, well, oxytocin, just a comparison between oxytocin. So I'll speak about carbetocin because it is long acting. Why I have said because it is GABA modification. It is synthetic analog of oxytocin with agonist properties. Just like oxytocin, it binds to oxytocin receptors in the uterine smooth muscle, resulting in rhythmic contraction, increased frequency of existing contraction, and increased uterine tone. So, acts on the oxytocin receptors, rhythmic contractions, and increases the uterine tone. Pharmacokinetics, oxytocin is intravenous, almost immediate action with peak concentration after 30 minutes. Compare it to a carbetocin, sustained uterine contraction within 2 minutes, lasting for about 6 minutes, and followed by rhythmic contraction for 60 minutes. Intramuscular oxytocin, intramuscular, slower onset of action, taking 3 to 7 minutes, but producing a longer lasting clinical effect up to 60 minutes. In case of carbetocin, intramuscular, sustained uterine contraction lasting for 11 minutes and rhythmic contraction for 120 minutes. Why it is more in case of carbetocin? Because its half-life is 40 minutes, almost 7 to 8 times that of the oxytocin. So here we have to, I would like to point out one thing, that if you give a single, it has been said according to some literature, not all literature, when you give carbetocin single dose, it is slow acting and it is continuous for hours together. Minimum 2 hours, maximum it has been seen that it is there for at least 10 hours. So a single dose of carbetocin, if can give protection for 10 hours, that is far more useful and beneficial than giving multiple doses of oxytocin under supervision, and which is not heat stable. So longer half-life, single dose, slightly costlier perhaps, but does not require refrigeration. So a single dose, prevention of PPH, not for treatment of PPH. The best part is that it prevents PPH because it prevents a lot of subsequent hassles. And according to some literature, as I just mentioned, the effect can be seen minimum 2 to 3 hours, even maximum up to 10 hours. So that is the beauty of this thing. Storage and transport, carbetocin conditions up to 30 degrees, 75-degree humidity in Indian condition, whereas in oxytocin, it requires logistics like refrigerator, storage at 2 to 8 degrees continuously, and protection from light. Now, difference between oxytocin and carbetocin. Carbetocin is never ever used for induction of labor, augmentation of labor. It is only given for prevention of postpartum hemorrhage, not for treatment of postpartum hemorrhage. Whereas oxytocin can be given for induction of labor, augmentation of labor, prevention of PPH, and treatment of PPH. So if you have to balance, you have to balance the patient's condition and the situation where you are practicing. That is very important. Next slide, please. Carbetocin is non-inferior to oxytocin. It is not saying it is better, but significantly superior to oxytocin. What I am saying, it is not non-inferior to oxytocin. Champion trials was held WHO. study designs, objective, patient enroll, huge amount of number of patient. The what was the primary outcome? The proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents was less. The proportion of women with loss of at least 1000 ml. Next slide. I think we'll go to the next slide. So here the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. So what is the conclusion? Carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. So it has been seen in case of carbetocin, the use of additional uterotonic agents requirement is much less. Next slide, please. Cochrane review. The author concluded for women who undergo a C-section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. In other words, when we give after delivery of the baby and the placenta, we give oxytocin. If there is extra bleeding, we give either prostaglandin or methergine. Whereas if we give carbetocin, for the at the proper timing of the carbetocin is very important. The need for methergine and prostaglandin subsequently is much less. And also, carbetocin is associated with less blood loss compared to centrometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse side effects. So, what is the message here? If you give oxytocin for the prevention of PPH, chance of requiring other urotonic agents like prostaglandin and methergine is more. Whereas if we can give carbetocin at the proper time, then the need for prostaglandin and methergine is much less. Next slide. Guidelines benefit or prevent uterine atony. Okay. Double carbetocin with the 100 microgram IV bolus, one recommended PPH. So it has to be given slowly. Carbetocin 100 microgram IV slowly. It is 1 ml 100 microgram. Single dose IV slowly over 1 minute. And then last one, non-inferior to oxytocin. Okay, next slide, please. Next slide, sir. Okay, next slide.
Coming to your experience, sir, since how long you have been using this
No,
drug?
I have been using this carbetocin. See, it depends on the whether it is available in the nursing home or the
Absolutely,
hospital. Some
absolutely.
hospitals are a proponent of carbetocin, some are not.
Correct.
So that we because I cannot advise the patient to bring
No,
carbetocin
no,
from
no,
outside
no,
before
no.
during when they get admitted because that is not allowed. For
And we
no
cannot disturb
hospital,
hospital's protocol.
totally will not allow. So
No.
I've seen, I'll share you a very honest case which had recently happened to one of my colleagues, and I was associated with that case. It was not my case. It was case of twin pregnancy,
Okay,
high blood pressure.
okay,
After the delivery of the second baby, carbetocin was given. Patient was okay for say around 10 hours or so.
okay.
After that, the pressure rose. She had significant PPH.
Oh,
Significant PPH.
secondary PPH.
Second, no, within not prime,
10 hours. Huh?
within 10 hours, not secondary. Yes, you can say it put in there, secondary PPH. Patient had to give in methergine and prostaglandin, and because of the high blood pressure, my colleague could not give the methergine.
Lethargy.
Then she had, it is what I'm saying has nothing to do with carbetocin. What I'm saying
Yeah,
is
that's
a
right.
real
Yeah,
life
yeah, yeah, correct.
because of the high significant rise of blood pressure, she has sort of coagulopathy. So
Oh,
that
wow.
needed to be treated with blood and plasma,
Correct,
and
correct. Yeah.
liver enzymes got deranged. We know all that, which happens in
Yes,
high blood
yes,
pressure.
yes.
So, but methagen prostatin had to be given. So why
Yeah.
I'm saying is that because in our next questionnaire
Yes,
it
yes,
will
yes,
come, if
yes.
carbetocin cannot
Doesn't
prevent
work.
the PPH, then
Yes.
what to do next?
Correct, correct,
So
correct.
so
This is a
that is
lovely
the
case, sir, which you described.
that is the
Lovely
so,
case.
and the
Yeah.
patient has gone home 2 days back.
That's
So
lovely. That's great to hear. Patient has gone home.
gone 2 days back. So
Yeah.
point is that see, we must take a very critical approach. We
Absolute,
cannot,
absolute, absolute.
because we must see the pros and the cons. Only then whatever so-called deficiency will be there, that will be made up. If
This
we
is
say everything
exactly
is
what
good
we
about
want,
the
sir. This
molecule,
is
then
yes,
it will
this
never improve.
this is exactly what we want. Opinion from your senior doctors guiding the team, whosoever is attending. Because this will give them confidence and the real world scenario, what it is and
But
what to
what
do.
I'm saying that the bleeding was not due to the less efficacy of the carbetocin,
No,
because
no,
in
no,
case
no.
of preeclampsia, it is saying that PPH is
Yeah,
there, coagulopathy is there.
correct.
She had INR raised, liver enzymes
My
deranged,
God.
platelet counts went down, blood plasma had to be given, creatine level went up. But after monitoring the patient in intense, not intensive care unit, she was there in the ward, but
Yeah.
she was monitored, rigorous monitoring.
Correct, correct, correct,
Things
correct.
situation improved and she went home.
Yeah. Good. The last point is very good. She went home peacefully. I mean,
Yeah,
that
she
is
went
good to
home.
hear. Yeah. Sir, would you think there's a benefit of using carbetocin as a first line drug to prevent PPH? Of course, in settings where it's available. Huh?
Yeah, and in the yes, in the settings where it just a second. Yeah, just a second. What is the benefit?
Of using carbetocin as a first line drug to prevent PPH.
Now, for benefit of you, carbidopa first line does that safe wherever it is available,
Available, yeah.
wherever it is available, it can be given. It can be given. Benefit is that if it is single dose,
Correct.
it does not require this logistics, so it
Yes,
can be
yes, yes.
used in rural areas also.
That is a great advantage.
Rural
Storage
areas also.
condition. Yes.
And if you can, in case, see, if we are suspecting that the patient will have PPH,
Correct.
then along with the carbetocin, we'll also keep other medicines ready.
Absolutely correct.
Are ready.
Absolutely
So,
correct.
but if in normal patients, where we also, you see, normal patient we give carbetocin and oxytocin also. We
Correct,
do not
correct.
wait for the PPH to occur.
No, no,
So
no,
all
no.
patients after normal delivery or C-section gets an oxytocin.
Very correct. Very
Gets an
correct.
oxytocin. So if whether we should give oxytocin or the carbetocin, that is the point.
Yeah.
So if we choose carbetocin, for suppose in a rural area, it is easy to keep.
Yeah.
Single dose, does not require require monitoring all the time. So it
You
is,
can give IM also.
and you can give IM also, you
IM
can
also.
give IV also.
IV
And
also.
because it is a sustained action, as I said, for 2 hours to 10
Correct.
hours, naturally the coverage time is high, and patient is hemodynamically stable. And if a single dose of carbetocin is effective, the need for other medicines go down, so the cost also comes down.
Correct, 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 correct. And
Yes,
cost of treating PPH is another thing. We have to use
yes,
so many
yes.
drugs. Yes. Sometimes operation also, physical measures, so many things.
Physical, yeah.
Coming to this, sir, there are some patients, as you said, of course, twin pregnancies, hydroamnios, where you can anticipate PPH. So, do you think anemia is a big risk factor for PPH in our country?
Yes, anemia is a very well documented, perhaps the most traditional cause for PPH in
Correct,
our
correct,
country.
correct, correct. And little loss of blood in them will disturb their hemodynamic very badly.
Yes, that is important. And whatever it is that, supposing the patient's age is less than 19 years
Okay,
and or more than 40 years,
okay.
because some people keep on having children till they reach menopause. In
And
rural area, we have
these
seen
days,
that.
people have children at late age also. These days, many
Yeah,
people are yes,
and it is very take a proper history. If
yes.
there is a past history of postpartum hemorrhage in
Ah,
previous pregnancy, there is a possibility. not due to any recognizable cause. Another
Yes.
PPH. Past history of PPH can also cause PPH this time.
It is very important that patient comes out with this past history properly.
Past history is very important.
Yes, correct. We'll go to
And
the
it is
next.
very, another thing is that some patients conceal the fact they take antiplatelet agents, because
Oh, yeah, yeah, yeah. Aspirin especially.
aspirin is there, because we give aspirin 75 milligram. I give up to 34 weeks in certain cases.
Correct, correct,
At 34 weeks, I stop.
correct.
I stop because she may go into labor anytime.
Anytime, yeah.
So I stop as a matter of policy. I stop the
Play
ecosprin 75
aspirin.
milligram at 34 weeks.
Coming to the next question. Any experience in RH negative mothers, sir?
No, it can be given. It can, no
It can
problem.
be. Yeah.
No, yeah, no problem.
Now, you have already answered this. If a doctor uses oxytocin for induction, can you use carbetocin for prevention? You have already answered this. I
Yeah,
don't
yeah,
want
yeah.
to waste your time.
Hmm.
Now, in which cases, sir, you prefer IV over IM route?
In case of quicker action, in
Quicker
case
action.
of long duration of action, we can give IM. But
IM.
for quicker onset, we will give the IV.
Correct. Correct.
Supposing, I'll say, supposing we know this is a case of overdensification of the uterus, anemic patients. There's a the PPH occurs within a few minutes, not
Correct.
after 4 hours or 3 hours.
Yeah, yeah, yeah.
So I will give not IM, I will give IV. So the
Correct.
onset of action is quicker, and I can prevent the PPH.
Very fast.
That is important.
So where we want fast onset of action, we prefer IV. Where we
Right.
want a longer duration of effect, we prefer IM.
That's right.
Yeah. And sir, your experience, how well it is tolerated?
So that is not a problem, not
There is
much.
no.
But at times, it is said theoretically it causes hypotension, tachycardia, nausea. All that stuff is always there. That is there with all medicines.
Yeah, yeah, yeah.
Nausea, vomiting, respiratory rate, hypotension, that is there with all medicines.
This is the question, sir, which you have already answered. Carbetocin, if patient is not responding, that what other things you did? You already had a case.
First we go, if it is the patient is not hypertensive, give methergine.
Bethargine.
If the patient is hypertensive, go for prostadine
Yes.
or
And not
misoprostol.
asthmatic.
Patient is not asthmatic. Yes.
Should it be kept as a reserve drug or a first line?
No, I don't think it should be kept as a reserve drug. It should
Reserve
be
drug,
used as a
correct.
first line.
First line.
If the idea is to prevent the PPH, keeping it in reserve and then trying to having a PPH and trying to tackle
Yeah, yeah,
PPH is
yeah, yeah. It
pointless.
makes no sense. Makes no
Makes no
sense.
sense.
Yeah. And sir, finally, your take-home message for the audience.
See that it is an acceptable medicine, satisfactory, but protocol must be maintained and it must be given at the proper time. See
Correct.
that these medicines are not given by the operating surgeon or the obstetrician who is conducting the delivery. In case of C-section, it is the anesthetist who will
Correct.
monitoring,
Correct.
giving the carbetocin, and in case of normal delivery, it is the labor room sister who is giving the carbetocin. So giving it at the proper timing is very important. And advantage, of course, there will be advantage. It is a single dose,
Yeah, yeah, yeah.
and if you give oxytocin IV, you have to give multiple doses.
Correct.
You have to change the IV fluid bottles. Chances of hypotension is more. Pulse BP monitoring is we have to
And
do.
ADH related side effects also can happen sometimes.
Antidiuretic hormone,
Yes.
yes. If you give too much, say, if you, some doctors say, I should not say panic. If the patient is bleeding, give around immediately 30 units of Cinto.
Oh,
It will
Baba.
reduce the urine output.
Yes, correct, correct, correct.
That is not seen here.
That is not seen. Well, sir, thank you so much. It was a lovely sharing your experience. I mean, those
Thank you.
case
My
which you
pleasure. My
shared was
pleasure.
lovely, to 10 us after a live practical case.
Yeah.
And the patient came out normally is a great
Yeah,
godsend.
yeah. I mean, it happened just 2 to 3 days ago.
Lovely. Thanks so much. And thanks all the doctors who took time at this time and attended the webinar. Very
My my
informative.
my thanks to all the doctors who have joined them
Yes,
face
sir.
to
Yes, sir. You're
face
my
and you are
sir.
not
Sir,
seeing,
thank you
but I
very much
think
for taking time
I
and
hope I
sharing
was
your
able to
experience.
convey what I wanted to do,
Yes, sir.
and I hope I will again be able to
Yes, of course,
share
of
my
course.
knowledge and experience
Yes.
when the next opportunity arises.
Yes, sir.
Thank you very much.
Certainly. Yeah. Thank you.
Have
Thanks,
a very
Bhuvan.
nice
Thanks,
weekend.
sales marketing team of Hitro. Thanks, Dr. Jaydip, once again. Good night, sir. You can sign off.
Thank you very much. My
Thank you.
pleasure. As always.
Thank you. Thanks, Bhuvan. We can sign off, Bhuvan.
Thank you, sir. Bye, sir. Good night, sir.
Bye. Good night.